Everybody.
So Dr. Amulya Sahu will be our first speaker who's going to have a challenging situation to show. On to you, Doctor.
Can I speak here?
Yes, you can. Yes.
Well, my target audience are beginners who are operating in a very difficult situation or not so privileged or with latest facilities. For them, it is directed that three things I want to mention here. In a situation like this, they should not panic if a situation like this happens. There are three P's they have to keep it in mind. One is patience, second is prayer, third is perseverance. See, here, what are the problems I created and I realized that it should not have happened. I made a small incision. I infused a lot of visco, and the visco went behind the iris. Iris started prolapsing, and I had no choice and except to extend the wound there, so that the least damage to the iris will happen. And here also, when I'm pushing the iris, that is not the ideal thing to do. I should have debunked it and then created a space there and then push the iris. But without doing that, I did it. Now you see the iris has been separated here, but still don't lose hope. There has been bleeding because of I was using this dialer, and with that somewhere I just pulled the iris and the bleeding happened. Whatever happens, your goal is to see that I will win at the end. That should be your commitment when you are in the driver's seat. And imagine you are driving a plane and everything is bad. Still, you should not lose hope, and your commitment should be to the passengers that I will land them safe. Here, the same principle I followed. Another thing, as you see that cornea, I should have cleared it with a in my jet thing, I didn't clear, so it was looking smuggy. So this is a, you have to remember, whatever happens, you should be in the driver's seat and deliver the good properly. That should be your commitment to the thing. My next video, can you show me? Can you share my next video?
Yes, you can. Yes, you can.
That is a, yeah. Show me that Rexis.
Rexis extension, yes. You have it with you?
Yeah. But I'm not getting it here. Can you help me?
Yes.
So just play the button. Just play.
If I
left lower corner arrow.
Play this one.
So in the bottom, yeah, the play, it's there also.
It was there.
Bottom left, sir.
Sahu, that triangle seen on the left side, Dr. Amulya.
This
Triangle
one.
left side down.
Which is in extreme
Correct,
left.
correct.
Yeah, there, yes.
Well, there is nothing much to say that this is a Argentinian flag thing. But what I wanted to share with you, even in this situation, don't try to catch the pigmented portion of the anterior capsule, and you can put in the lens in the sulcus, and that too a foldable. So ideally, it will be you can put a bigger haptics lens, but here I put a foldable IOL directly over this thing, and the result have been superb in both the cases. So difficult situation can happen to anybody anywhere, but I think we are showing the same thing again.
Yeah, you're showing the same thing again. You have that other video to show.
The other video.
Mr. Sunil, can you show the second
Yes,
video?
ma'am. Yes, ma'am.
Please. Can you stop this video? He'll put the video and you can talk, sir.
So this is a thing happens to many people if you have a hypermature cataract, and so things can happen.
Yes, you could see, talk on this. Dr. Amulya,
See there now see how it's slipping. So don't fiddle around here or pull anything, because it will go to the posterior capsule. So nothing has been lost yet. Just be observant when you are doing this, irrigation aspiration. You have to be very careful and be very mild and very controlled in your movement, because any pressure in the capsule, it will tear. So be very gentle here. And in this case, the incision is big, so I have nothing to fear. So this is the time when you have to understand that you are not pulling the anterior capsule. You have to just see the position your Simcoe behind the tag and see that you are pulling only the cortex, not the capsule. So I'm directly putting the lens and the result is good. Nobody will realize that you had such a problem in the OT. So patience, perseverance, prayer and perseverance, these three things. I think I may look little old timer talking about prayer, but I believe that prayer makes a difference, because once you have a prayerful heart, your ego dissolves. Otherwise, you start behaving as if you are the God and then end up being a dog. So thank you so much for sharing.
Thank you
Thank you, Chitra.
Sahu, for bringing out 2-3 points for discussion. Dr. Saurabh, are you there? Dr. Saurabh?
Yeah, yes, ma'am.
Yeah, one question I had, which you could explain further. In an intermittent cataract as this, so one, of course, I'm sure, like in phaco, we would start off with a smaller rexus and then enlarge it. But finally, when there is so many multiple points where the rexus has extended, don't you think it makes more sense to place a 3-piece IOL instead of a single piece, because the bulky haptic of single piece can rub on the iris and not an ideal?
Yeah, I think definitely 3-piece IOL makes more sense. And also, while using 3-piece IOL, make sure that both the haptics are in the sulcus, because many times we miss this point. We put the 3-piece IOL, and when we are dialing, sometimes one haptic goes in the bag and one is in the sulcus. That also leads to refractive error because of the tilt. And of course, but still, I have seen many surgeons putting a hydrophilic IOL even with extended rexis. According to their experience, it does well, but I have not used that in the surface.
Okay. And one other question I have is, in an SICS, if you've had an iris prolapse, does it not make sense to enlarge the incision a little and go ahead and do a sandwich technique, which will hold the iris behind and pull out the nucleus?
Yeah, I think here the surgeon was very experienced, so he could go ahead. But I think for beginner, the main problem, iris prolapse starts even with the premature entry of the incision. So if the iris prolapse happens, issue is that like he showed, iridolysis chances are very high. So for beginner, I would say that take care of the iris first. Like you can even use iris hooks to retract the iris properly. Okay, so it gets out of the way. So further trauma to the iris is avoided. And then you can go ahead with your surgical steps. I think for a beginner, it makes more sense, because for nuclear prolapse and other things, for an experienced surgeon, he can still do, but for beginner, it's difficult.
In an SICS where you need to rotate the nucleus out into the anterior chamber, these iris hooks for a beginner surgeon will not be a hindrance?
Pardon me?
For a beginner surgeon, since the nucleus has to be brought out into the anterior chamber, having these iris hooks or capsular hooks, would they not find it as a hindrance for them?
No, in fact, I think there are good techniques how to use iris hooks in such cases. I think even Dr. Ravindra sir has videos where you can put it sub-incisionally also. But I think once you know the technique, I don't think it's a problem. Only during delivery, you can remove the sub-incisional iris.
Thank you very much.
One question I wanted to ask Professor Ruchi Goyal. Ma'am, once this iridodialysis happens, as it happened in the first case, for the benefit of the beginners, once such a thing has happened, would you do the iris repair in the same sitting, or you would take it up later?
It depends on where exactly and what is the extent of iridodialysis. Suppose you have a iridodialysis superiorly and it's of a, say, let's put it about 2 clock hours or just 3 clock hours. Sometimes you can just leave it, because what happens is it gets covered by the lid and it usually doesn't hinder in the long term. But if it is a large iridodialysis, especially if it is situated somewhere in the visible area, then it is always better to suture it and repair it at the same sitting.
Thank you very much.
Thank you, ma'am.
Any other questions, Satyajit, before we go on to our next speaker?
May I come in this regard?
Dr. Sudhir wants to ask a question.
Yeah. There are two things basically. Iris hooks and beginners are both the contradictory things and should not be attempted. And these are the small things. Even one larger tunnel can be handled. And even I have videoed. In the meantime, I can show you if you want later on. But for these, even how many 2, 3, 4, 5 hours of iridodialysis can be settled with air bubble if you know the things properly. So idea is just that carry on your procedure. Take it out nucleus with the larger tunnel, and then you can push back the iris and put a big bubble like air bubble, and it will settle down. So I have videos of even more than 6 hours, 7 hour dialysis and settled without this. So even repairing is, for my practice, I have done so many, but it's quite rare. But it's don't require any like suturing, all that. It's settled down if you know the proper base of pushing back and putting the big air bubble. Yeah.
Thank you very much, Dr. Sudhir, for your input. Dr. Satyajit, can you introduce our next speaker? Thank you so much, Dr. Amulya Sahu. Please stay with us. We would need your inputs all the time.
Thank you.
Thank you, sir.